causes like which are not encountered due to like any acquired infection or any toxic or any metabolic cause. So first of all, we'll quickly look at a quick approach. Like whenever a case of leukodystrophy comes to us, so the first rule is we have to look at the age of the patient, whether the onset of the leukodystrophy was during the infant period, during the neonatal period, or during the adult period. So certain white matter disorders are very peculiar to the neonate period. For example, MSUD, neonatal hyperglycemia, which we will encounter in the neonate period. Such a similar appearance, if we encounter at a later age, then we should not consider them as diagnosis. So in this presentation, we'll discuss about various pediatric as well as adult causes of leukodystrophies. So the second thing, first of all, after looking at the age, we have to understand whether the patient is having normal myelination, patient is having hypomyelination, or patient is having demyelination or dysmyelination. So as we all know that myelin structure is composed of water and along with 70% of its dry mass is fat. So because of this, myelin deposition leads to reduction of both T1 and T2 relaxation times, and normal myelin appears hyper-intense on T1 and hypo-intense on T2 relative to the gray matter. But the rates at which the reduction in T1 and T2 relaxation times occurs and it completes are different, and T1 shortening by myelination happens earlier and quicker, whereas T2 shortening is a more gradual process. So, as we all know, because of this, T1 weighted sequence is used to assess myelination in the first 6 to 8 months of life, and T2 weighted sequence is useful for assessment beyond 6 months of life. So, normal myelination occurs in a very precisely organized temporal and spatial pattern according to the fundamental law of myelogenesis. As we all know, it happens central to peripheral, caudal to rostral, caudal to cranial, and rostral to ventral. So, there is a famous myelination clock which helps us guide, like whenever we are reporting, we can keep it for our easy learning, or we can look at the various atlases available online to look for whether the brain of the child is normally myelinated or not. So this is the famous myelination clock which guides us about the myelination. As such, we all should know what are the structures which are myelinated at brain, which include the dorsal brain stem, posterior limb of internal capsule, and the pericentral white matter. So these are basically the early myelinating structures, and certain diseases, in fact, affect these early myelinating structures because they have high energy consumption. So beginning with our first discussion, so we'll keep it an interactive discussion. You all can post your answers in the chat. So you can see there are two cases, the case 1 on the left and the case 2 on the right. So what do you think? Like which of, like what is the are the pathologies different in both, and what is the difference in the pathologies? Like which one is hypomyelinating, which one is or demyelinating leukodystrophy? So can I see the chat?
Yes, you will get an option in the top bar which says chat.
Yes. Yes, I got it. So very good. People are even answering. I just asked hypomyelination and demyelination. So first is a case of Pelizaeus-Merzbacher disease. First is hypomyelination, and second is demyelinating leukodystrophy. Now, what is the difference between hypomyelinating and demyelinating leukodystrophy is that in hypomyelination on MR appearance, what do we see is we see mild hyperintense signal of the white matter. Whereas in demyelinating leukodystrophies, the white matter signal is much more conspicuous. Like the white matter hyperintensities are much more conspicuous, and associated more commonly, there is associated T1 hypointense signal. Whereas in case of hypomyelination, the white matter signal will be only mildly T2 hyperintense, and T1 signal can be anything. It can be hypo, hyper, or even uh, it can be iso, as in this case, hypo or even hyper, depending upon the amount of myelin deposited. So first case is a case of hypomyelinating leukodystrophy. which is Palliasis-Merzbacher disease, and second case is a demyelinating leukodystrophy, that is vanishing white matter disease. So, what is the basic difference is that hypomyelinating leukodystrophies are clinically and genetically heterogeneous disorders which are characterized by a permanent deficiency of myelin deposition in the brain. So, it is the lack of normal myelin deposition. Whereas dysmyelinating or demyelinating leukodystrophies are relating to abnormal myelin. Now, earlier the terms dysmyelination and demyelination were used separately. So dysmyelination refers to abnormal myelin formation, whereas demyelination is once the myelin is formed, there is abnormal breakdown of myelin. But in the latest article by Van den Am, they have divided the leukodystrophies into hypomyelinating and demyelinating and removed the word dysmyelination. So in this discussion also, we will consider as hypomyelinating and demyelinating leukodystrophies. So so first rule was to look at the age. Second rule was to understand whether it is normal myelination, delayed myelination, hypomyelination, or demyelination. Now, the next rule we'll see by looking at a case. So this is a case of a patient is an IV drug abuser and patient is of a relatively older age and patient has history of recent onset cognitive decline. So this is the case. So everyone can post whatever they are thinking, their diagnosis. Patient is, or is it a leukodystrophy? Is it its mimic? Is it hypomyelinating or demyelinating leukodystrophy? Yes. So someone has posted it is AIDS-related demyelination. So very good. The clue was IV drug abuser and like the way you told and hypo, yes, because T1 is nearly iso-intense. However, the fact is that this is a case of HIV encephalopathy. And HIV encephalopathy, similar to the genetic leukodystrophies, we see very symmetric white matter hyperintensities. But we knew that the patient was IV drug abuser. So whenever we have a case of leukodystrophy and how are they identified by symmetric white matter hyperintensities, then we should first rule out any acquired cause, whether there is associated any seropositivity. So we should actively look for any HIV infection or the patient is taking any drugs, for example, methotrexate toxicity or any other toxicity, any radiation exposure. So all these have to be first ruled out before labeling a patient with a leukodystrophy. So this is our second rule. Third rule that we have to rule out any acquired treatable causes and mimics. Now, the next rule is we have to look at the pattern of involvement. Now, we have looked at the age of the patient. We have decided it is a demyelinating leukodystrophy. We have ruled out mimics. And now, whenever we have to decide, like, what is the type of leukodystrophy, like, we have to narrow our differentials. So, we have to look at the pattern of involvement. So, the pattern of involvement can be associated with the white matter involvement. For example, if whether the pattern is subcortical, diffuse, or periventricular, or the other pattern is the gradient. For example, there is PA gradient or AP gradient. So the involvement is frontal predominant or parieto-occipital predominant. Apart from this differentiation, we should also look at the involvement of in any other gray matter structures are also involved along the white matter. For example, the involvement of basal ganglia, cerebellum, brainstem, dentate. So based upon the which structures are involved or whether they're involved or not, we can narrow down our differential diagnosis. So based on various patterns, first of all, looking at the pediatric leukodystrophies, we have subcortical patterns, periventricular patterns. Subcortical, we have Canavan, L2-hydroxyglutaric dysuria, Kearns disease. So we look at all these cases one by one. And in periventricular, we have metachromatic leukodystrophy, Krabbe's disease, MPS, and neuronal ceroid leukocytosis. Then we have diffuse patterns and we have vanishing white matter disease, we have Van den App disease in it. And then we have frontal pattern where we have Alexander's disease more commonly involved and parieto-occipital pattern where we know that X-linked adrenoleukodystrophy is more commonly involved. Then there can be involvement of the deep gray and white matter, which are characteristically seen more commonly in the mitochondrial disorders. But there are certain other disorders also which can involve both the gray and white matter. So whenever we are looking at a case of leukodystrophy, we can keep these tables. Like there are various classifications, various approaches. We can keep them with us so that we are able to report the case correctly. However, there are certain very common diseases which we should know, we should know by ourselves only that these, if come and they are classic, especially if they come as spotters, then we should be well versed with them. Then similar to the pediatric, we have adult pattern of leukodystrophies. So this is an image from a recent article from a radiographics. So it is a very good article and it has given an approach how to approach leukodystrophies which present first time in adult. So apart from these, like looking at the pattern, we also have to look at certain special features. For example, so we'll answer a few questions and then we'll try to know which like important things we have to look for except apart from the patterns. So of these cases, which of the leukodystrophies can show contrast enhancement once gadolinium is given? So everyone can post their answers. Yes. So most of them are giving correct answers, but many of them are also giving like only X-linked DLD, only Alexander's disease. So all of them can show contrast enhancement. And the parenchymal enhancement is commonly seen with X-linked adrenoleukodystrophy and Alexander's disease, whereas MLD and Krabbe's disease can also show contrast enhancement, but usually they show contrast enhancement of the cranial nerves. For example, optic nerve in Krabbe's disease, there can be enhancement of the associated cauda equina nerve roots as well. Then so first thing, apart from the pattern, we can look at the contrast enhancement. So another thing, so whenever we are doing any case of leukodystrophy, we always include MRS as well because we have to rule out mitochondrial, we have to rule out certain leukodystrophies which can have various involvements. So already people have started answering. So many are answering Canavan's disease, but many are answering the correct answer also. So the correct answer is tall NA-like peak is actually not only seen in Canavan's, but also seen in Sala's disease, which is a hypomyelitic leukodystrophy, which we will see in a subsequent slide. In PLP null disease, actually very small NA peak is seen because it is a type of PMD, that's Palacios Merz-Becker disease, in which there is deletion mutation. And Kearns-Sayre disease is not associated with NA peak, but it is a mitochondrial disorder and it is associated with lactate peak. So we have to look for MRS, certain specific features, for example, tall NA peak, we have to look for lactate peak, and there are certain other peaks as well, which we can look for example, lipid peak in case of Jogren-Larsen syndrome. Then we have to look at the clinical features of the patient as well. For example, the question which comes whenever a patient of leukodystrophy comes, so whether the patient has a large head or not. So many of the leukodystrophies can be narrowed down based upon the whether they have large head or not. So here the question is, which of the patients of these will show small head rather than large head? So actually, none of them shows microcephaly. Uh, vanishing white matter may not show macrocephaly, but as such, not known to show microcephaly as well. So then we have to look for macrocephaly, we have to look for contrast enhancement, we have to look for MRS findings. Then we also have to look for any other features, for example, intracranial calcifications or cysts. So which of the following are associated with calcifications on MR? Yes, all of the above are associated with calcifications, and we'll also look for, we'll also see these cases in the subsequent slides. So apart from that, other features can be seen, for example, subdural collection. So some of the leukodystrophies or some of the white matter disorders or metabolic disorders can be associated with subdural collections, but also not only them, they form a differential diagnosis of each other. So which of the following is not associated with subdural collection? Yes. So Alexander disease is not associated. So these are just few simple questions, but whenever we are approaching a leukodystrophy, we can answer these questions and reach to a diagnosis. So which of these following do not show hyperdense thalami on CT? Yes, Bentonite disease does not show. MLD can show. So basically, the main thing which we have to remember is all the lysosomal storage disorders can show hyperdensity on in thalami on CT and corresponding T2 hypointensity. So we have to, these are the important features which we have to look. Apart from that, we have to look for any cysts and we have to look for any CSF intensity, any cavitations. Yes. So the next features which you have to look for is if there are any clinical clues. For example, we have looked at the MR, but before actually MR, if first comes the age and then comes the clinical clues. Already the patient will be coming with a very strong clinical clue and we can directly make the diagnosis. For example, ichthyosis. If the patient is having periventricular pattern of leukodystrophy, and there are many DDs. There is MLD, there is Krabbe's disease, but patient has ichthyosis and we see lipid peak on MRS. So we'll be having Jogren-Larson syndrome. Yes, excellent. So there can be cardiac abnormalities associated with Kearns-Sayre disease, retinal pigmentary abnormalities associated with Cockayne syndrome, Kearns-Sayre disease, parietal clonus associated with adult onset Alexander's disease, and forehead syndrome associated with polar 3 leukodystrophy. So we have to look, we are clinical radiologists and we have to look all the features along with clinical clues as well. So the basic rules are we have to look at the age of the patient. We have to understand whether it is hypomyelating, demyelating. We have to rule out any acquired treatable causes and mimics. We have to look at the pattern of involvement and we have to look for any special features, cyst, calcification, hyperdense thalami, contrast enhancement, and we always have to look for the clinical clues. So based on this, we'll start discussing our cases. So the first case is of a 7-year-old girl who was a preterm with seizures and spasticity and EEG showed left frontal spike wave discharges. So these are the images. These are T2 weighted images. So I'll just scroll and if you want to answer, you can answer or you can tell your findings. So what we are seeing is we are seeing that there is white matter hyperintensity involving the entire cerebral hemisphere, but there is certain pattern. And there is also involvement of gray matter structures. There's thinning of corpus callosum. There is involvement of the brainstem. And these are the this is the non-contrast T1 weighted image, and this is the post-contrast. Actually, there is not much enhancement in the periventricular region, but there is a peculiar feature that there is T2 hypointensity in the periventricular rim with T1 hyperintensity. But we see some other enhancement. We see a parenchymal enhancement in the left-right occipital region. So what is the diagnosis? Yes, already people have answered. It is Alexander's disease. Now, why it is not Canavan's disease? Because there are certain specific features which we can see in Alexander's disease in this case. So, what is Alexander's disease? It is also known as fibrinoid leukodystrophy. It is a sporadic leukodystrophy, and typically it presents less than 4 years of age, and atypical features can be seen in older age. And these patients usually who present typically will die by 4 years of age. They have macrocephaly and they present with seizures and they have a poor lifespan. Whereas the atypical ones can present with bulbar symptoms or like palatal clonus, these kind of features. So, how do we diagnose Alexander's disease and what specific features are present in our case? So, earlier Alexander disease was diagnosed by biopsies. However, Vandenaar established a 5-point MR imaging criteria and suggested that using this criteria, there is no need to do biopsies which are invasive and we can diagnose, we can strongly suggest a diagnosis with MR imaging criteria confirmed by genetics. So what is the criteria is there is extensive cerebral white matter hyperintensities as we see in our case, but there is a frontal predominance. So here clearly we are seeing that there is more frontal involvement as compared to the posterior involvement. Although it is almost reaching up to the subcortical new fibers, however, it is a progress stage. If it was an earlier stage, it would have started in the periventricular location and gone to the subcortical location. Then the other point is there is a periventricular rim. So this we can well appreciate in the next image. So there is a periventricular rim of T2 hypointensity and corresponding T1 hyperintensity. So this is another feature which is specifically seen in Alexander's disease. Then apart from that, there can be hyperintensity seen in the basal ganglia as well as the thalami and the brainstem. So both the dorsal pons as well as medulla can be involved. So all these have a point. So there are points for basal ganglia and thalami and brainstem abnormalities. And apart from all these abnormalities, there is a point for contrast enhancement of various structures. So there can be enhancement of the ventricular lining or periventricular rim of that tissue, or there can be enhancement of white matter. There can be enhancement of optic chiasm. Like all these structures can show enhancement. So if these features are present, then we can be very strongly suggestive of that it is Alexander's disease. Apart from these specific features of periventricular T2 hypointensity, T1 hyperintensity, frontal predominance, basal ganglia, thalamic involvement, and brainstem involvement, there are a few new signs which have been very recently described in this year only. In one of these signs is the involvement of the medulla. So there is a particular involvement of the medulla. Very good. Someone has answered chipmunk sign. So it is a very recent sign described in AJNR. So it is a characteristic medullary involvement. So what is there in it? So as we see, like the face of chipmunk, there is involvement of the in the medulla. There is the hyperintensity involves the pyramids as well as the like central olivary nuclei. The peripheral olivary nuclei are spared and remain T2 hypointense, so giving the appearance of the eyes of the chipmunk. Apart from that, rest of the mid part of the medulla is involved. However, the inferior cerebellar peduncles are spared, giving the appearance of the cheeks of the chipmunk. So this gives an appearance of the chipmunk face on medulla. And they have suggested in their paper that atypical cases, when we are not sure whether it is Alexander's disease or not, if we see this sign, then it can be quite specific and we can at least suggest that it is an Alexander's disease to further confirm the diagnosis. So this is the article where they have compared the chipmunk's face with the appearance of that on the medulla. Then this is another case. It's one of the cases which was there in my fellowship period. And we see all the typical features of what described by Van Damme. We see a beautiful T2 hypointense rim, which is T1 hyperintense and shows contrast enhancement as well. We see frontal predominant hyperintensities, and also we are able to see that this periventricular T2 hypointense rim, which has been described in Alexander's disease. We are seeing the involvement of the basal ganglia, and we are also seeing the involvement of the medulla with the chipmunk sign. Apart from that, there are certain features which may not be very known but are commonly associated with Alexander's disease. For example, there is a web in the aqueduct of Sylvius. So this web is also commonly described with Alexander's disease. And some people say that the associated hydrocephalus seen in Alexander's disease may be because of this aqueductal stenosis. So this is the next case. So first we have discussed a typical case of Alexander's disease. So this video was taken by one of my colleagues at my institute. So this patient presented with 41-year-old male presented with late onset cerebellar ataxia with these characteristic tremors. These are palatal tremors. So this is again a very important clinical clue for the diagnosis. So anyone can, yes. So already what someone has given the answer, Dr. Arka, that it is an adult onset Alexander disease. And what I was going to show has already been told. So others can also answer. So we are able to see few non-specific periventricular hyperintensities. But what characteristic feature is seen is that there is marked atrophy of the medulla as compared to the pons. So this gives an appearance of a tadpole, and this is known as tadpole sign, and it is one of the signs seen in the adult onset Alexander's disease. Apart from the this sign, there can be some enhancements which already someone told earlier. There can be some enhancements in the periventricular region along the veins, which are known as ventricular guidelines, which can also be seen with Alexander's disease. So this covers the Alexander's disease. So we have to remember the Van der Naap criteria. We have to remember the chipmunk sign. We have to remember the adult onset, uh, Alexander's disease, the palatal clonus, and the tadpole sign. So coming on to the next case. This is a case of a 9-year-old male with headache, seizures, cognitive decline, poor scholastic performance, and hyperpigmentation of the skin. So this is a spotter. I think almost everyone will answer. Yes. So very good. It is X-linked adrenoleukodystrophy. So we see the characteristic in we see the characteristic periventricular involvement in the parieto-occipital region, and we see also the characteristic enhancement seen in the adrenoleukodystrophy. The gene associated with it is ABCD1, which was positive in this patient, and this patient was X-linked recessive. So this is X-linked adrenoleukodystrophy. So X-linked adrenoleukodystrophy, also known as Bronze-Schilder disease, it is due to the absence or deficiency of acyl-CoA synthetase, and it results in impaired oxidation of very long-chain fatty acids. So there is a characteristic enhancement which is seen in this X-linked adrenoleukodystrophy. So there are 3 zones of enhancement. So first of all, the part which enhances is the intermediate zone, and it is the zone of the active demyelination and inflammation. The zone inner to it is the necrotic zone, which does not enhance, and the zone outer to it is peripheral demyelination, but without inflammation. So what enhances is the presence of demyelination plus inflammation, and this is the intermediate zone which enhances. So whenever the radiology residents can get this as spotter, so this question can be commonly asked, the zones on post-contrast sequence. So classical presentation is seen in preteen boys presenting with deteriorating cognition and scholastic performance. There can be associated Addison's disease, and 80% of these cases have posterior predominance. The first sign can be the presence of hyperintensity in the corpus callosum, which spreads from posterior to anterior and central to periphery. So we have already discussed that the intermediate zone often enhances and can also show diffusion restriction. Apart from that, there are certain variants of X-linked adrenoleukodystrophy. The most commonly seen pattern is the posterior pattern, but in 10 to 15% cases, the anterior pattern can also be seen, and that is known as frontal variant of adrenoleukodystrophy. Apart from that, when the white matter involvement, more than the white matter involvement, there is involvement of the spinal cord, corticospinal tracts, and cerebellum, then it is known as adrenomyeloneuropathy, which is the second most common presentation apart from the posterior predominant adrenoleukodystrophy, and seen in 35% of the patients. So this is another case, a 3-year-old male with psychomotor regression, seizures, and spasticity. Here again, we see the periventricular T2 hyperintensity with hypointense signal T1. And in this case, there is not much enhancement. So, but there is a diffusion restriction in the periphery, which is in the intermediate zone. Here we see that there not much of the cerebellum, that cerebellum white matter is not involved. But what this case is to show is that apart from the typical features which are seen in X-linked adrenoleukodystrophy, there can be certain atypical features. For example, there may not be enhancement in adrenoleukodystrophy. Actually, 50% of the cases have known to enhance, rest of the cases may show or may not show enhancement. Apart from that, as seen in this case, the optic tract can also be involved in it as well as the corticospinal tract, although these features are more specific or like more commonly encountered with other leukodystrophies like Krabbe's disease. So here we see the characteristic spleen involvement. So this is a case of another case of X-linked adrenoleukodystrophy, but in this case, so this patient had some atypical features. So just wanted to show that it may not be always very typical. So also important to know whenever we are getting such a case. So we may be asked this, what is Lewis MR scoring system? So it is basically a severity score. So it is a 34-point score and it is used to guide whether stem cell therapy can be useful for the patients with adrenoleukodystrophy or not. So it is based on the location, extent of the disease and atrophy. It divides brain into 9 regions and 23 subregions, and each is characterized by the presence or absence of atrophy, and further each region is characterized by the presence of normal or unilateral signal abnormality or bilateral signal abnormality. So what you have to know is it is a 34-point score, and you have to know is that more than 13 score is considered severe. So it is an important score to guide stem cell therapy and should be known to us. So we finished a second pattern, which is the posterior predominant periventricular pattern that is seen the most commonly in the X-linked adrenoleukodystrophy. Now we have next case of a 2.5-year-old boy with psychomotor regression, spasticity, and demyelinating polyneuropathy. So what you feel as the diagnosis? Yes. So someone has correctly answered. It is metachromatic leukodystrophy. So apart from this, we are able to see that there is not involvement of the cerebellar white matter, not involvement of the gray matter structures, but there is characteristic periventricular involvement with sparing of the U fibers. Now, many people describe, we all know that a tigroid pattern is described in metachromatic leukodystrophy. Here we see some small hypointensities within the T2 hyperintensity. So these are because of the preserved myelins in the perivascular regions in the region of overall demyelination. So this is seen in metachromatic leukodystrophy. So this is another case from literature which shows the typical tigroid pattern, which is not so much typical in our case, but still it was seen. So the diagnosis is metachromatic leukodystrophy. So tigroid pattern is present in MLD, that we all know. But yes, so it is present in all the three. It is present in metachromatic leukodystrophy, Krabbe's disease, and early reports of Palacios-Merzbacher disease have also shown that tigroid pattern can be present in them as well, especially on neuropathology. Although MR, it is difficult to recognize, but still it has been described. So other thing which we should know is that metachromatic leukodystrophy is a lysosomal storage disorder characterized by reduction or absence of aryl sulfatase A. So this is an important enzyme, and we actually look at the values to confirm the diagnosis, and it affects both central and peripheral nervous system. That is why it can be associated with peripheral neuropathy. There are three types depending upon the age of presentation. It can be late infantile, or it can be juvenile or adult onset. The most common one is the late infantile, which has typical characteristic like features, clinical features. Patient present with gait disturbances, visual and motor impairment, and death usually occurs by 4 years of age. And adult variant is rare, and it is associated with neuropsychiatric features and cognitive decline. Then what do we see is as we saw, we see periventricular hyperintensity is not showing contrast enhancement, but there is characteristic tigroid pattern. And on like apart from this, there is the spread of hyperintensities is centrifugal. Like first of all, there is periventricular involvement. Splenium of corpus callosum is early to be involved, and later on it spreads into the further regions. Though subcortical fibers are spared, but very late in the disease, there can be extensive involvement as well. The Typically, the subcortical white matter, projection fibers, and cerebellar white matter are usually preserved till end stages. The late involvement of cerebellar white matter can be one of the differentiating features from Cabez disease, which also shows periventricular hyperintensities, which also shows tigroid pattern. However, the cerebellar white matter can be more and earlier commonly involved in Krabbe's disease as compared to the metachromatic leukodystrophy. Now, whenever there is adult variety, which is rare, these patients present with neuropsychiatric features. So we have to know in such cases, we may not see the typical periventricular pattern. We may see a frontal predominant hyperintensities and in later stages, non-specific diffuse cerebral atrophy may ensue. So, in case of metachromatic leukodystrophy, the frontal predominance of periventricular hyperintensities is common in adult age, whereas in case of Krabbe's disease, the posterior predominant is common in adult age. So, we see another case of 11-year-old boy with cognitive decline, spasticity, and asymmetric onset of left hemiparesis and ataxia, followed 3 years later by right side involvement. So first there was left hemiparesis, and then the child had right-sided involvement as well. There was cognitive decline, spasticity. So all the features pertaining to some white matter disorder. So what do you feel is the diagnosis just based on this image? We can see the further image as well. So someone is telling pecan, Polgy. So we'll see the other images. So what are we seeing? We are seeing the involvement of the pericentral white matter. We are seeing the involvement of corticospinal tract, and we are seeing along the, yes, very good. We are seeing abnormal signal intensity along the corticospinal tract, and we are seeing the involvement of the optic radiations. Then on coronal images, we see the characteristic involvement of the corticospinal tract and also the presence of the white matter hyperintensities along the central white matter. So this is again to show the involvement of. So in ALS, do we see commonly the splenial involvement? And what is the age of ALS? So we are seeing 11-year-old child with cognitive decline. And we are seeing that there is involvement of the corticospinal tract. So corticospinal tract, along with splenium involvement, thinning of the corpus callosum. So what we see in ALS is this picture. However, we do not see commonly involvement of the splenium of corpus callosum. So some people have correctly answered. It is in fact a case of Krabbe's disease. Now this may seem atypical, but involvement of corticospinal tract is one of the very important features of Krabbe's disease. And we may not always encounter a periventricular involvement in case of like typical diffuse periventricular involvement in case of Krabbe's disease. What is specific is there is posterior involvement and involvement of optic radiations along with the involvement of corticospinal tract and along the entire corticospinal tract. In fact, this pericentral white matter is extending and along the entire corticospinal tract is involved. And so this is one of the specific features of Krabbe's disease, and it is differentiated from ALS because it is also involving the optic radiations, just not the corticospinal tract, and it is also involving the splenium of the corpus callosum. So in Krabbe's disease, another specific feature can also be seen. So we see periventricular involvement. We see this corticos. There are different patterns which can be seen in Krabbe's disease. We can see periventricular involvement. We can see corticospinal tract involvement. Apart from that, there is one structure which can be thickened. And if corticospinal tract hyperintensity like this, yes. So someone has correctly answered. There can be thickening of the optic nerve and the optic chiasma along with the presence of hyperintensity along the corticospinal tract. So that can be characteristically seen in the Krabbe's disease. So actually, this was the patient's image from outside films of the same patient. This patient initially presented only with involvement of right-sided corticospinal tract and bilateral optic nerve radiation. So that accounted for the asymmetry of the patient's involvement, that first the left side was involved and then the right side was involved. So this 3-year prior image is put here to just tell you that the Krabbe's, the initial involvement may be very atypical, and we may just see, or very asymmetric and atypical, and we may just see involvement of one corticospinal tract, and in such cases on follow-up it progresses and can involve the second corticospinal tract as well. So involvement of just one tract again points towards Krabbe's disease rather than the ALS. So, Krabbe's disease, also known as, it is also a lysosomal storage disease, and it is characterized by deficiency of galactocerebroside, beta-galactosidase deficiency. Now, so it is a lysosomal storage disease. So it can again present with a hyperdense thalami on CT, and it can also be seen in MLD. 80% of the patients are females. The most common presentation is in the infantile form, where the patient has irritable and feeding difficulty. However, adult forms are also seen, and adult onset Krabbe's, as I told, has more commonly posterior involvement as compared to the frontal involvement seen in MLD. So the periventricular white matter and corticospinal tracts are involved. Subcortical U fibers are spared. I've not shown one feature, but early cerebellar involvement is also one of the features which differentiates it from MLD. So there are alternating halos around the dentate nuclei. And cranial nerve involvement and enlarged optic chiasma is a feature which can be seen. Yes, sandwich sign, very good. It can be seen with Krabbe's disease. Now, cranial nerve involvement as well as cauda equina nerve root thickening and involvement can be seen in both MLD and Krabbe's disease, but optic nerve chiasma thickening is more commonly seen with the Krabbe's disease as compared to MLD. So whenever we have to differentiate MLD and Krabbe's, it may be difficult because both may show periventricular involvement, but corticospinal tract involvement is involved in Krabbe's disease. If it is involved, then it points towards Krabbe's disease. Optic chiasma and optic nerve thickening is more common in Krabbe's disease, and early cerebellar involvement is common in Krabbe's disease, whereas in MLD it is very late to be involved. In fact, the last to be involved. So we see another case. So till now, we have seen various periventricular involvements. So we saw a frontal predominant periventricular involvement in Alexander's disease. We saw a posterior predominant periventricular involvement in X-linked ALD. Then we saw just a periventricular involvement in both Krabbe's and MLD. Now we look for another case of a 23-year-old female who she was totally fine initially, and just from last 2 years she started having difficulty in walking, dragging of the right lower limb, and few months later right upper limb stiffness also started. Earlier she was very good in academic performance, now she has decline in academic performance, and she has recent onset cognitive decline as well. So these are the images. So we again see a periventricular involvement. Apart from that, we also see some the centrum semiovale involvement, although it is asymmetric, and we see diffuse atrophy. So on T1, we see that it is hypointense, and on FLAIR, it is hyperintense. And there is some characteristic feature on diffusion. It is showing diffusion restriction. And on SWI, very small blooming focus is seen, although in this disease, more calcifications are seen. And when we look at the post-contrast sequence, we see small foci of enhancement, which we thought, but it is not actually enhancing because on T1 also, they are hyperintense. So what do you think of the diagnosis? So we have periventricular involvement with few foci of diffusion restriction and T1 hyperintensities. In this case, it is not seen, but calcifications and enhancement can also be seen. So it is periventricular involvement, and there is no, it is not subcortical involvement for Canavan's disease. It is not diffuse involvement for vanishing white matter disease. One very important clue, which was our first rule, has to be applied in this case. and then we may be able to reach a diagnosis, though it is a rare case. So what is the age of the patient? Aicardi-Gouttiere is common in which age? The age of the patient is a 23-year-old female. So we see a periventricular involvement with diffusion restriction. Yes, brilliant. It is CSF1R associated leukodystrophy, and there is associated thinning of the corpus callosum, and it is also known as adult onset leukoencephalopathy with axonal spheroids and pigmented glia. So it is a heterozygous autosomal dominant leukoencephalopathy. Now, what was the most important clue in this patient was initially totally well, and this is an adult patient, and we see periventricular involvement with marked atrophy. Patient also has cognitive decline. So whenever we are seeing periventricular involvement in adults, apart from this diagnosis, we also have to keep adult onset Krabbe's, adult onset metachromatic leukodystrophy in our diagnosis. But the presence of such kind of diffusion restriction can be little more specific for this diagnosis. So we have to keep it a higher level as compared to the other diagnosis. There is almost always associated thinning of the adjacent corpus callosum in this case, and there can be associated calcifications which are known as step ladder calcifications along the corpus callosum, though it was not seen in our case. So this is a case of CSF1. It is associated with mutation in the CSF1R gene, and this is one of the important differentials of an adult onset leukodystrophy with periventricular pattern. So we have covered many of the periventricular patterns and which are commonly encountered in children as well as in adults. Now let us move to another case. So it is a case of a 5-year-old male with language delay, febrile seizures, and ADHD. So what do we see? Now we are moving to another pattern. So instead of periventricular pattern, we have subcortical pattern. Apart from that, we see that there is marked hyperintensity involving the corpus striatum, though globus pallidus is not that much involved. And we see a characteristic involvement of the dentate nuclei. This is very typical of L2-hydroxyglutaric aciduria, very correctly answered. And we see some diffusion hyperintensity, but no diffusion restriction, and associated T1 hypointensity, indicating it is a demyelinating disorder. So what do we see is, this is a very characteristic feature of L2-hydroxyglutaric aciduria. We see subcortical involvement, and we see associated dentate involvement, and there is sparing of the central white matter. So the periventricular white matter in the corpus callosum in this case are characteristically spared, and usually the brainstem is not involved in these cases. And the presence of involvement of dentate nuclei and the involvement of putamen have been seen in nearly almost all the cases. So this is a case of L2-hydroxyglutaric aciduria. There is preferential involvement of subcortical white matter over the deep white matter and periventricular white matter. And also in this case, there is more frontal involvement as compared to the occipital involvement, which we can also somewhat see in our case. So apart from that, the internal capsule, corpus callosum, cerebellar white matter, and brainstem almost always spared. The most important point to know is dentate nuclei and putamen are almost always involved in this case, and globus pallidus can also be involved. So why it is important? Like, it is an important disease because it is associated, like if we follow up these patients, they can actually develop glioma, especially astrocytomas. So it is very important to keep a look at these patients, although they present at a little like school going age, but and they can live up to more age, but they have a propensity to develop astrocytomas. So we have to have a look at these patients and do regular follow-ups. So differential diagnosis of this L2-hydroxyglutaric aciduria. So what is this? This is an image taken from Osborne. So someone can answer. We see a characteristic MRS finding. Yes, it is Canavan's disease. We see that there is diffuse involvement, and there is a characteristic Na peak on tall Na peak in this case. And what is difference, like how do we differentiate? Now, in this case, there is diffuse involvement. But L2-hydroxyglutaric aciduria in later stages can also show more central involvement as well. But usually there is characteristics vary. But in this case, the presence of involvement of globus pallidi are more common than putamen. Usually, the putamen are relatively spared in Canavan's disease as compared to L2-hydroxyglutaric aciduria, where they are almost always involved. And dentate nuclei involvement is also more common in L2-hydroxyglutaric aciduria. So, how I have remembered is Canavan's is C for central. So, globus pallidi involvement is more common in case of Canavan's, and putamen are spared. And L2-hydroxyglutaric aciduria, on the other hand, more commonly involves putamen rather than there is no as such specific criteria, but we see that rest of the metabolites are much smaller as compared to this tall NAAP. Because if we see Na, but we are able to see other metabolites as well. Here we see the other metabolites are quite small as compared to the tall NAAP. So that is what we call for a tall NAP. So in case of Canavan's disease, there are bilateral symmetrical signal intensities, cerebral white matter. They can be diffuse. And first, as we all know, that there is subcortical U fiber involvement first, and then there is pairing of putamen and caudate nucleus. Dentate nucleus is also not involved. And there is, as compared to the L2-hydroxyglutaric aciduria, there is no frontal preference for Canavan's disease. It can have multifocal and confluent involvement. So we see another differential of these diseases in an 18-year-old boy with chronic progressive external ophthalmoplegia. Okay, so already Dr. Arka has answered even before seeing the image. So here actually the diagnosis is made from the we have to look at the images, but very important clues are given in the history itself. There are cardiac conduction defects and CPEO, which are quite commonly seen in the Kearns-Sayre disease. So what I wanted to show here is that subcortical pattern of involvement is the other differential for subcortical pattern of involvement is Kearns-Sayre disease. In this, apart from the features which we saw in L2-hydroxyglutaric aciduria, there is very common involvement of the globus pallidi. Now, in L2-hydroxyglutaric aciduria, the thalamic involvement and brainstem involvement is not that common. Whereas in Kearns-Sayre syndrome, the brainstem involvement and the thalamic involvement is quite common, as we see in mitochondrial disorders. Here, cerebellar white matter can also be involved, and dentate can also be involved, but what differentiates it from is not only these features from L2-hydroxyglutaric aciduria, that there is more GP involvement, that there is brainstem involvement, but the most important clue lies in the history. So here we see the characteristic subcortical involvement with sparing of the central white matter. There is GP involvement, and there is also presence of the cerebellar white matter involvement. Apart from that, we see few diffusion hyperintensities, though they are not showing restriction. And what we see that the cystic changes seen in the globus pallidi are actually showing peripheral blooming. And because the patient has presented at a progressive stage, we are able to see that there is blooming along the gray white matter junction, indicating that it is towards a neurodegenerative stage. So we see the presence of the lactate peak. So here again, MRS plays a role to differentiate these from each other, where lactate peak can be seen in Kearns-Sayre syndrome because it's a mitochondrial disorder. So bilateral symmetrical lesions of globus pallidi and subcortical white matter are commonly involved. In fact, calcifications can also be commonly seen. Although we didn't have CT for this patient, we may not pick them up on SWI, but we may be able to pick them up on CT. But in our case, they were not seen. Caudate nucleus is also affected. So in contrast to L2-hydroxyglutaric aciduria, putamen is less predominantly involved, and the brainstem and thalami are affected in most patients with Kearns-Sayre syndrome. So we have discussed the subcortical pattern. The important ones are L2-hydroxyglutaric aciduria, Kearns-Sayre syndrome, and Canavan's disease. So whenever a subcortical pattern comes to you in exam or comes to you for reporting, you should always keep these as differential diagnosis and remember these cases. So we see another case of a 17-year-old male with seizures, spasticity, cerebellar ataxia, cognitive decline, and macrocephaly. So we see certain characteristic features. We see that there is almost diffuse white matter involvement. But apart from that, we are seeing the involvement of cysts. Yes. So it is a case of Van disease, that is megalencephaly leukoencephalopathy with a subcortical cyst. So we see diffuse white matter involvement. Apart from that, we see the cysts, which are more in literature also, they are more commonly seen in frontal and temporal poles. So here also we encounter the cysts in the frontal regions and very small cysts in the temporal poles as well. So here we see the cystic lesions. And in this case, corpus callosum is also involved, although corpus callosum may be later involved in case of Van disease. So in Van disease, it is an autosomal recessive disorder caused due to MLC1 mutation. So the patients usually have slow neurological deterioration. So they may progress up to adult age, but they have the macrocephaly like starts at very young age in infancy itself. However, the cognitive decline and other disorders, like other problems, start later at the age. So initial to begin with, this megalencephaly leukoencephalopathy with subcortical cyst is subcortical, and then it progresses towards the center. So now, because we have looked at demyelinating leukodystrophy with cysts, so we see another case, and I want you all to give a differential diagnosis. So we see a very small brain, so it is microcephaly rather than macrocephaly. Then we see that there are anterior temporal pole cysts, and we see very prominent very prominent sulcal spaces, extraaxial spaces, and marked white matter hyperintensities. And also we see presence of calcifications. Yes, torch infection is one of the very important differential. However, it came out to be positive on, yes, very good. So this is a case of Aicardi-Gouttiere syndrome. So torch infection will definitely remain one of the top DDs. However, we also have to keep we have to keep Aicardi-Gouttiere syndrome in its TB because of the microcephaly, because of the presence of cysts and presence of calcification. And there is no presence of, although we cannot tell because so much atrophy is there, but we are not seeing any malformations in this. However, both the torch and Aicardi-Gouttiere syndrome will remain in its TD. And in fact, yes, there is ventricular dilatation, and that is associated. So there is a lot of ventriculomegaly, and that is commonly associated with uh, Aicardi-Gouttiere syndrome. So this turned out to be Aicardi-Gouttiere syndrome. So this is another case where there is microcephaly. Here again, we have ventricular dilatation, and we have some lesion-Kefli pattern as well. And apart from that, there is prominence of the hydrocephalus. EC is what I don't understand. Okay, we'll discuss. So here we see again the prominent anterior temporal spaces. Aicardi-Gouttiere syndrome patients live for very short while, so they usually die at a very young age. But torch infections can progress at a greater age. This was a case of very infant only. So this is another case. This is a separate. So yes, we can keep type 1 glutaric aciduria as differential. However, we are not seeing any hyperintensity in the basal ganglia. Neither are we seeing any hyperintensity in the white matter. Yes, again, Zellweger syndrome can be a differential, but what we see, so Menkes kinky here, we are not seeing here, like patient did not have that characteristic clinical feature, and we are not seeing very prominent vessels in these cases. What we are seeing are prominent anterior temporal spaces. So already you told one diagnosis in the previous. So why can't it be that diagnosis? Yes, it actually turned out to be congenital CMV. Patient was positive for CMV IgG. So all these are DDs. Glutaric aciduria type 1 can be a DD, but there should be more hyperintensities in the brain as well. And these patients also present in neonate period, glutaric aciduria type 1. And but the presence of anterior temporal cyst, again, we should keep torch as a DD. And Menkes kinky here, we are not keeping as DD. Patient, I didn't give any history, and also the patients should have prominent vessels, which are not so well seen in this case. And yes, of course, Menkes kinky here, glutaric aciduria, all these will have prominent subdural collections. Although here what we see are prominent extraaxial spaces rather than subdural collections. In case of subdural collections, Menkes kinky here and glutaric aciduria type 1. Yes, here we see is the simplified sulcal pattern, which is more commonly encountered with the torch infections. So because we are discussing leukodystrophy, and we discussed the calcis, and we also discussed Kern's-Sayre, which is also cause of calcification. Now we see a case which is just for a spotter, that there is presence of leukodystrophy, there is presence of calcification, and there's presence of both calcification and cysts. And this is a relatively older patient. Yes, very good. So already you have answered. It is a case of Labrin's disease or leukoencephalopathy with cyst and calcification, and it is associated with SNOT 118 gene mutation. So this was all about, like, we discussed about various causes of cysts and calcifications. Now we discuss another diffuse pattern of a 4.5 year female with gait difficulty. So what do we see? So we see diffuse white matter abnormalities. There is no subcortical periventricular involvement. Like, this may be a progression of an earlier stage, but this patient did not have macrocephaly. There was no NA peak on MRS. So here we see, as compared to that case where tall NA peak was there, as compared to the other metabolites which were very small. But here we see NA peak is there, but the other metabolites are not very reduced as compared to the NA peak. That NA peak is not overshadowing the others. So Sala's disease can be one of the differential, although I have not given corpus callosum here. Usually in corpus callosum, in Sala's disease, corpus callosum is almost always very thinned out. And apart from that, so we cannot, so Sala's disease is a hypomyelinating leukodystrophy rather than demyelinating. So here we see is demyelinating. And Canavan's disease, I already told, there is no NA peak, there is no macrocephaly. Patient has normal head size and patient has diffuse white matter involvement. Yes, it is a case of vanishing white matter disease. And we already saw the same case in our first image, where we differentiated from PMD versus vanishing white matter disease. Nevertheless, all these will remain DDs. We have to give these as DDs. So whenever any case of diffuse white matter abnormality is coming, we have to think of vanishing white matter, and we have to think of Canavan's disease at a progressive stage. So we are not seeing any earlier stage, but we have to look at the pointers, whether MRS is showing NA like peak, or whether the patient has macrocephaly, which is more commonly seen in Canavan's as compared to the vanishing white matter disease. But always we can give a DD in our exam as well as in our report and then further genetics can confirm the diagnosis. So the aim is that we should go towards a correct approach so that we are guiding the clinicians. So in the guide. So what you have done in infants, if we see inversion on flare, can be called white matter disease in infants. Flare may invert because of increase. No, in infants, like, flare is not very reliable because the infants, as we all know, that because of the increased white matter content, as you already told, that flare actually for 2 years, till 2 years of age, we do not rely on flare. We are looking at T2 and T1 as the main sequences, as we'll further discuss in hypomyelinating as well. So flare is not the primary sequence in case of infants. So the diagnosis, as you all told, is vanishing white matter disease. It is characterized by diffuse abnormal cerebral white matter. And as compared to the MLC, now we saw that Vandenap disease, we saw that there was diffuse involvement. And we also saw that such appearance can occur in, we all thought that it can be a DD for vanishing white matter disease as well. But if we are at earlier stage, the difference can be that the vanishing white matter disease progresses from the periventricular towards the subcortical rather than MLC, which first starts in the subcortical location. So, as like Van den App disease, vanishing white matter disease also has slow progression. And as we discussed that 3 leukoencephalopathy, however, these patients can have rapidly progressive form affecting the infants, which are fatal by the second birthday. So initial periventricular and then subcortical involvement, there's no enhancement, there is no NA like peak, rather NA is reduced. So we have discussed till now the periventricular pattern, the subcortical pattern, the diffuse pattern. And because we were discussing vanishing white matter disease, which has very much liquefaction, as we saw in our, sorry, 1 second. As we saw in our case, there is liquefaction. So now we are moving towards cavitatory leukoencephalopathy. So just to finish, yes, you have already told it is a mitochondrial complex deficiency. So here what we see is we see cavitating leukoencephalopathy. What characteristic features which we should think in case of why we have to give mitochondrial definitely in this as a differential. First of all, because of the presence of this kind of diffusion restriction. This peripheral diffusion restriction indicating necrosis is very characteristic of this mitochondrial disorder, especially the nuclear DNA disorders. The nuclear mitochondrial DNA disorders, the complex deficiency ones, are associated with cavitating leukoencephalopathy, whereas the mitochondrial ones like POLG or MELAS are associated with cortical abnormalities. What another feature is very characteristically seen in mitochondrial disease in this case is the presence of involvement of mid blade of corpus callosum. So whenever we are seeing the involvement of corpus callosum, but characteristically the superior and inferior blade are preserved. In this case, it is relatively involved, but the most important, the most characteristic part is involved in the center part. So it is like a sandwich. So whenever we are encountering this kind of mid blade involvement, then we should always give mitochondrial as one of the differentials. And it in fact turned out to be mitochondrial complex C deficiency. Now, mitochondria itself is a big topic. And in fact, these complex deficiencies can be differentiated, like complex 2 can be associated with the succinate peak. So all this we are not covering, but in general, you remember that when we are seeing diffusion restriction, mid-blade involvement, and obviously lactate peak, then we should give mitochondrial as a DD. Now we see another case of a 27-year-old male who presented with difficulty in walking, tremors, and decreased vision.
Sorry, Dr. Smiley, how much more is it? Otherwise, we can make, if it's too much, then we can make another session probably. It's already
Ma'am.
8:10.
Okay, sorry, ma'am. It is the last demyelinating case. I can finish
Okay.
demyelinating. Hypomyelinating we can do next time.
Yeah.
Yes. So we come towards this case. So here we are seeing some very characteristic feature in a patient with difficulty in walking, tremors. So we are seeing periventricular hyperintensities. Apart from that, we are seeing the cerebellar white matter involvement, MCP involvement, and we see a very characteristic feature of involvement in the spinal cord. Yes, very good. So it is a case of LBSL. So whenever there is involvement of the periventricular white matter and cavitating leukoencephalopathy, yes, DARS2 gene is associated with it, and involvement of the brainstem, MCPs, and very characteristic appearance of involvement of central as well as the lateral corticospinal tract. So this is a case of LBSL. And one very important feature is that LBSL is usually associated with a very large lactate peak. So if we are encountering, especially in adults, we are encountering a case where spinal cord involvement is there along with periventricular involvement, and we are getting a small lactate peak, then we may rethink. But when we are getting a very large lactate peak and this characteristic spinal cord involvement, then we should consider a diagnosis of LBSL as one of the top priorities. And the major criteria is involvement of the white matter with sparing of the subcortical U fibers, dorsal columns and lateral corticospinal tract, and pyramids at the level of medulla oblongata, decussation of middle and meniscus or bone. There are other minor criteria as well. So we are finishing the demyelinating. So there are many more hypomyelinating. So we can cover it in the next chapter, next session.
Perfect. Yeah, yeah. So I'll coordinate with you for the next session because it was really amazing the way you took it through a case series. It was really interesting. And I think everybody in the audience was also enjoying too much because they were so actively replying and being so interactive. So thank you so much for such an excellent presentation on such a difficult topic. You were doing real justice to it, I would say. Uh, so,
Thank you so
uh, Smiley, I'm going to get in touch with you and we'll coordinate for the next session, right?
Sure. Thank you so
Thank
much,
you.
everyone. And thank you so much, Ref. Thank you, ma'am, and thank you, Arpita, ma'am, as well, for giving me this opportunity. And thank you all for your excellent participation. Thank you.
Thank you, everyone. Take care. Good night. Have a
Thank
good
you.
weekend. Bye.
Thank you.